now. And just introduction thank you all for joining us today in our virtual education activity here in Qatar. So some technical difficulties. So moderator will be myself, Abdul Jabbar, and Dr. Bako, one of our consultant here. So today we have Dr. Hari Shufflebarger. He will speak about his lessons he learned in 30 years of spine surgeries. Dr. Hari Shufflebarger is a well-known spine deformity surgeon, pediatric spine deformity surgeon. He's currently working at Paley Orthopedic Institute in Palm Beach, Florida. And he's a clinical professor in Miami University. And he's a past president of SRS and one of the founder of the harm study groups. So he has like 20 book chapters, more than 50 articles, and we're looking forward to hear from you, Dr. Hari. I will stop the sharing and you can share your screen.
Okay, thanks, Abdul Jabbar. Let's see if I can.
If you can use the microphone because there's some echo in the voice.
Okay, you need to disable your screen sharing. Abdul, you need to disable your screen sharing.
Just 1 minute. So I stop share. Now. Now no share from my side.
Okay.
Is there any problem in sharing the screen?
It won't share. You're off, correct?
Yeah.
You know what you may have to make me the host.
No need, because in the meeting, no need. You just go and share the screen.
I get a message that says, host disabled attendee screen sharing. So you disabled my screen sharing, is what it says.
Let's okay, can you try now? Yeah, I think, yeah, you can now. We can see your screen, Dr. Shufflebarger.
You can?
Yeah.
Okay.
It's on the Zoom page, and now we can see your presentation. If you can put it in the presentation mode, now we can see it clearly.
Okay, perfect. So as Abdul said, I've been doing pediatric spine deformity for more than 30 years. Initially, I did both adult and children, and I stopped doing adult deformity probably about 15 years ago. And I wanted to really focus on pediatric deformity and not work as hard. Of course, I stayed busy and worked pretty hard. And I'd like to go over some things that I think that I've learned over the years in the disclosures. And I have a list of 12 things that I'll discuss in some in more length than others. And when I looked at this talk again in preparation here, I added a number point 13 and 14, which we'll see at the end. So we'll just go by the numbers 1 through 12. And the first thing that is sometimes difficult to do or to accept is that you should not be worried about getting help. And people are more than willing to help you. These are my good friends and peers, Peter Newton and Randy Betts, and I call upon them for advice, for review cases, for cases that I think may be a problem, for any number of reasons. So feel free to call upon people you know, to your mentors. Dr. Bacco, I'm sure, would be available anytime, as would I. So don't be afraid to ask for help, because it's there. And this, as I said, may be complicated cases, controversial cases, as it's always going to be very helpful. And I still do. I ask for help several times a month, and probably more to reinforce my decision making, but to see if there are any other thoughts on difficult problems. And it's a great idea and a great experience to visit key opinion leaders throughout the world. And I've been very fortunate to visit some real giants in spine surgery. My initial 2 mentors were Tom Whitesides at Emory University and Bob Kaiser, who was a founding member of the Scoliosis Research Society, who was my first partner in practice. And Bob, I didn't do a formal fellowship, but I went to Dr. Kaiser's house at least once a week to run all my cases by him. And then over the years, I've had the very good fortune to spend some time with Eduardo Lucchi, spend a lot of time with Jean Dubussy, who spent 6 months in Miami on sabbatical. I spent a lot of time with Jürgen Harms. We were partners in the development of Moss Miami and put forth the theory of how to use Moss Miami, and particularly anterior column load sharing. Harms was a proponent of that from the start. And we taught that most everywhere. I also had the great fortune to spend some time with Professor Suk of Seoul, Korea. And I went there in the early 90s to learn how to put pedicle screws in deformity. And I wound up going back 6 times to Seoul between 93 and 2001 to learn how to do screws in deformity and to learn how to do 3-column resections, at which Professor Suk was an expert. Professor Suk is a very talented spine surgeon, excellent technique. And finally, I visited Peter Newton, he's my contemporary, a little bit younger than I am, but Peter's a very bright guy and has a lot of.
Hello.
Sorry, Dr. Harry.
الله يحفظك ويبارك فيك. شلون اخبارك؟
The voice is not clear.
الحمد لله. يحفظك الله يبارك فيك.
If I get a little bit closer, is that any better? Is that better?
It's very clear, Abdul Jabbar.
يعني شنو طالع؟
I guess it's better to be closer. So particularly for you young people, don't be afraid to call upon people and say you'd like to come watch and learn. And that's been very useful throughout my career. Are you hearing me okay now?
Yes, Dr. Harry.
Okay. Lesson number 3 is more is better and less is better. I learned more is better in terms of spinal fixation over the years, and less is better regarding levels instrumented. And we'll look at this. I started on the left with Harrington rods, and next came Lucchi rods, and that was more and more fixation. And this is the Harrington and the lateral. And the advantage of more fixation points I learned very early on. It permits contouring of the rod and allows you to reconstruct the sagittal profile into more normal alignment. And the one on the right is a neuromuscular case done with Lukey instrumentation in about the late 70s, early 1980s. And it's contoured a very nice sagittal profile. And this is a more recent case with multiple levels of screw fixation, allowing satisfactory correction of the severe scoliosis. So more is better in terms of fixation. And less is better.
Gamer.
Less is better in terms of levels. And I've become very much a fan of selective thoracic fusions, avoiding the lumbar spine whenever possible. And this is an example of a double thoracic curve stopped at T11. And we'll look distally. What's better, L3 or L4?
Excuse me, the speaker is muted.
Dr. Harry's voice has disappeared. Abdul Jabbar?
Sir, please unmute.
Dr. Shufflebarger, can you unmute yourself? Dr. Harry?
Yeah, I hear you.
Yes, please. Please, everybody,
Here.
mute
In
yourself.
here.
Okay, can you hear me okay?
Yes, please. Yes.
Yes,
Okay.
sir. It's better now.
Okay, my microphone got muted somehow.
No problem. Sorry for this.
It's okay. So L3 versus L4 in this type of curve. And the rules to stop at L3, you need to be 2 levels below the apical disc space, which is L1, 2. So L3 is okay. The disc space between L3 and L4 should be parallel or closed on the right side, and this is parallel. So it doesn't make any difference how far outside of the CSVL the apical vertebra is. 3.5 centimeters has been quoted as the ideal distance. But this is a good case for stopping at L3. And here you see stopping at L3 with good sagittal profile. And statistically, this will last a lot longer than something ending at L4. The Lenke 1C curve, as you see here, I've been a fan of selective thoracic fusions for 25 years probably. And the Lenke ratios were published in the 1990s for Cottrell-Dubuisset instrumentation. And the ratios compare the curve size, the apical vertebral rotation, and most important, the distance from CSVL to the apical vertebra. And when it's greater than or equal to 1.2, a selective thoracic fusion is going to be successful. So this one very much meets the 1.2 ratio. And this was, although pretty equivalent curves in terms of Cobb measurement, it was a candidate for selective thoracic fusion, which was carried out. And this is a much better looking result than fusion to L3 or L4. So whenever possible, I would do a selective thoracic fusion. This is another example. Bending, that means the lumbar curve is structural. And we stopped at T12, which has a small rib. And to preserve the lumbar spine, and motion should be full. How about this curve? Probably not very many people would do this, would do just the thoracic curve. But we did a selective thoracic fusion, stopping at lumbar 1, preserving the lumbar spine. And this is his appearance. It really doesn't look very bad. And the radiographs again. So when you have a Linky C or Linky 3 or 4 curve, I would very much consider stopping at the end of the thoracic curve and avoiding the lumbar spine. The function will be much better and it will probably last much longer. Lesson number 4 are those lessons I learned from Jean Dubussé. I became acquainted with Jean in the early 1980s, 1981, 1982. And when the Cottrell-Dubussé device was first introduced in the United States in 1985, I was probably the first US surgeon to use the Cottrell-Dubussé instrumentation. And through collaboration with Jean Dubussé, he and I wrote this little pamphlet on how to do Cottrell-Dubussé for all types of curves. And I learned a lot from Jean. He was the first to think really in the 3 dimensions. We're still looking at the 3 dimensions and trying to figure that out completely. Jean had a very good grasp on it back in the 1980s. And this year, Jean Dubussé is going to be awarded the Lifetime Achievement Award by Scoliosis Research Society, which is long overdue, and he's certainly deserving of that. So I learned about the 3 dimensions from John, and we got this publication combining the deformity in the coronal and sagittal plane to get a combined measurement. And this was more towards a 3D evaluation of the spine. I published a couple of papers and textbooks, chapters on the theory and mechanisms of the Cottrell-Dubussé device, and including where to place hooks, how to bend the rods, and the sequences of those. I also published a paper on fusion levels and hook patterns with Cottrell-Dubussé instrumentation. And this is all thanks to collaboration with Jean Dubussé. Jean has continued to be active, and he was instrumental in developing the EOS radiology for 3D spinal evaluation, which is present in most centers doing deformity surgery all over the world. Excuse my dog if you can hear him. And I also spent some time with Hubert Lindell in Montreal, and he was a very good thinker in 3 dimensions of spine. And here's the EOS, the 3D CT-like rendering that can be produced. And this is the Scoliosis Research Society 3-dimensional spine classification. And they've come up with this view from the top. The green arrows demonstrate the amount and the direction of the deformity, such as lordosis in the lumbar spine, kyphosis in the thoracic spine. And that work by the 3D classification committee continues. So by the increasing understanding of the 3D spinal anatomy, hopefully we can formulate better surgical plans and improve surgical outcomes.
Na desesperação e propagação da infecção de Covid-19 no nosso país. Gostaríamos também de lembrar que atualmente não está disponível nenhuma vacina para a Covid-19 em todo o mundo e por isso o cumprimento de todas as medidas que por esta plataforma temos da faculdade é a melhor forma. Portanto, a apresentação...
Something is wrong with the audio.
Mute everybody.
The audio,
Someone is taking the
it's not
picture.
clear.
Please mute other people, please.
So there is a 3 candidate, I cannot control them, called Najwan, DW, Oscar, and Lex. I cannot mute them. So please, if you mute yourself.
You can debar them. Please remove them.
Yes,
Okay.
now it's okay.
Okay, lesson 5 is listen to the neuromonitoring team. We have spinal cord monitoring and deformity surgery for a reason, and that's to tell us when there's impending neurologic damage. I think there are more lawsuits or legal actions in the United States for surgeons' failure to listen to the neuromonitoring team. And I'll just show you an example. Our team consists of anesthesia, surgeon, and the nursing people. And when you get this no traumatic incident, the waves change. And what's the significant change? Probably a 50% decrease in amplitude of motors would trigger an alert. And that the alert means the monitoring team needs to check their equipment and the upper extremity responses. And that's to tell you that there truly is an alert. Anesthesia, and frequently, this is the problem, the blood pressure tends to gradually go down. Maybe they've lost a little bit too much blood. But the anesthesia team should elevate the blood pressure using pressors if necessary. If there's a question about blood volume, transfuse the patient and begin the wake-up test. The surgeon should release any distraction that's present. He should remove everything from the spinal canal, particularly flow seal or gel foam. And he should check the spinal cord for compression if there's been any laminectomy done. So this should all happen simultaneously, and the OR team should know it, but they should know what to do. And this is an example. It's a 15-year-old male, otherwise normal, had a normal MRI. And this is his x-ray. And this was an AIS of about 120 degrees. And our plan was to expose it, do the thoracoplasty, do ponte osteotomies T4 to T12, place our screws, and then do a asymmetric vertebral column section at T9, and then place the rods and correct the deformity. And we had good monitoring to start with. This is the SSEP. And everything was going nicely. We were getting towards the end of the ponte osteotomies, and we were informed the motor evoked potentials were gone or significantly diminished. So we did our checklist for monitoring alert. Removed the gel foam. The blood loss wasn't very much, but the blood pressure was low. So we elevated this. While we're waiting for the wake-up test, I went ahead and placed the screws. This may not be such a good idea, but I have a hard time standing around. And we did get the screws in. And the upper extremity motors were normal, waiting for wake-up, transfusing. Wake-up test, patient awoken, moved both lower extremities. The motors returned poor on the left side, they were okay on the right side. So we elected to abandon the VCR and complete the posterior spinal fusion with instrumentation. And he awoke and moved both lower extremities. And this was about 20 years ago, and I think I was very lucky. The first day, he was pretty much back to normal. And by 3 months, he was basically back to normal. And this was a definite spinal cord injury. And so this was years ago, and I think I would have approached this significantly different today. I would have placed the boy in halo gravity traction for probably 4 weeks. And many times this will allow gradual correction with the patient awake and obviate the need for a 3-column resection. In addition, I would look a little more closely at the MRI, and I suspect he had a type 3 spinal cord bilinky, and that's where the cord changes shape at the apex. And this cord has a high incidence of monitoring alerts. So I would probably put a rod around the convex apex and compress that before I did anything else. If I had no monitoring alerts, I would go ahead and do the Pontes, place the screws, and place the concave rod. If there were ever monitoring changes, I would go ahead without even hesitating and do a laminectomy over the 3 levels of the apex and take out the pedicles to decompress the cord. And I think this way you will avoid monitoring changes in spinal cord injury. So listen to your monitoring team. Lesson 6 is protect the dura. Whenever you have dura exposed, you and your assistants should be protecting the dura at all times. And, instruments and people seem to be attracted to these soft spots by some supernatural type forces. And, injury by direct contusion can change life in the blink of an eye. So protect the dura at all times. Even passing instruments back and forth, you need to be extremely careful. If you do have a cord contusion during surgery, you go through the same drill that we went through for spinal cord monitoring alert. Be sure there's no subdural hematoma. You may even consider an intraoperative myelogram. And we'll go to lesson 6, and that's the power of the pedicle screw. Probably very few of you went through the eras of spinal instrumentation from Harrington to Lukey to Cottrell-Dubussé to pedicle screws. And I think that the pedicle screw has made a tremendous difference in deformity surgery. And I can appreciate the power of it. And this is Hook's original article from 1995, of which most of the deformity world thought he was crazy for using screws in thoracic deformity. If you remember, I had been going to Seoul from about 1992 to learn how to do this. And his results with segmental screws was much superior to hooks or screws in a hook pattern. And not only in the coronal plane, but the rotational correction was outstanding. And this was presented at the SRS 1994, and the article was published in 1995. And gradually over the next 10 years, segmental pedicle screws became the standard for deformity correction. We can show the derotation very well. This is just placing the screws, and you should pay attention to the tips of the screws on the convex side. And here the concave rod has been placed, and you'll note that the screws are a little different position than they were with nothing in it. Finally, the second rod is placed in, and you see all the screw tips are medial to the rod, and that connotates derotation. And finally, the segmental rotation is carried out, and the screw tips are projecting almost the same as the concave rod, and that tells you that you've got very good derotation. To do successful spinal surgery and deformity, I think there are a number of keys. You need to master a screw system, and it's difficult if you go using 4 or 5 different instrumentation systems to really learn a system. If you really learn it, then you're able to improve it. And finally, as you know, you need to do a meticulous spinal fusion. Techniques of screw insertion. I began freehand. There are a number of articles in the 90s and 2000s about the number of poor placement of freehand pedicle screws being anywhere from 9 to 20% in the bad position. Some image-guided systems came along, then FluoroNav came along, and finally navigation and robotics. If you look at PubMed, there have been over 300 publications in the past 15 years on screw placement. So, as good as we think we may be, obviously screw placement technique is not solved. Navigation is not 100%. I used for years the C-arm solely. The past 6 months I've used a device called TrackX, and because the O-arm is present in the hospital I'm at now, I've started using navigation a little bit. So I'm continuing trying to improve. We did a CT post-op study on 20 patients about 10 years ago by our technique, and probably 98% of them were where they should be. So using a fluoro technique or even freehand technique, you need to find the optimal starting point. And using the fluoro technique, my wife, if you'll excuse me just a minute, I'll be right back. I learned it. And then we would stimulate it electrically. And if you know the length of the flutes on the drill, and this is a transverse anatomy, where the distance from the starting point to the canal is going to be about 20 millimeters. So if you see this projecting, if you see the tip of the drill projecting medially at less than 20 millimeters, you're going to be in the spinal canal. So if you know the geometry and the lengths, you'll get an intraosseous trajectory almost all the time. So that will ensure intraosseous position. You repeat the stimulus of OTMG, recording from intercostal muscles, abdominal muscles, and lower extremities. Finally, when you're done, you should review the AP fluoroscopy and look at the screw tips. And we see this one is going to be lateral. If you don't have good screw placement, you're going to have difficulty reducing big deformities because the screws will be loose and they'll move as you try to change the spine. There's been over the past 10 or 15 years a whole body of literature that supports the use of segmental screws in spinal deformity. And since 2010, there's many, many more. So this is the standard, being segmental pedicle screws. And in general, the correction is better, the fusion is shorter, less implant complications. This obviated the need for most anterior surgery. But segmental screws are a little more expensive and a little longer operating time. This is one case with segmental pedicle screws that I'll show you. These are identical twins, 13 years old. And this is what they look like. And this is what their x-rays look like. Pre-op, and this is post-op. And their clinical appearance. There's more in talking about the power of the pedicle screws, and I talked about avoiding anterior surgery. This was our practice-changing paper on the posterior approach for lumbar and thoracolumbar AIS using segmental pedicle screws. And then the second article, Matt Geck wrote for me comparing it to anterior procedures done by Dr. Leckie. And this is an example of only posterior segmental pedicle screws, and good clinical correction, excellent radiographic correction, excellent reduction of lumbar lordosis. Another advantage of the pedicle screws is the ability to correct high-grade spondylolisthesis. Prior to pedicle screws, this was almost an impossible condition. You know, it was best done with anterior and posterior procedures. I'm in favor of reducing spondylolisthesis. This does a number of things. It gives you direct canal decompression. It corrects lumbar sacral kyphosis. It prevents the acute cauda equina syndrome. And it provides a posterior tension band with an anterior column support. This will all decrease the pseudo rate and improve the quality of fusion. So this was our article published 15 years ago on 25 adolescent patients with high dysplastic spondylolisthesis. 24 of the 25 were followed more than 2 years with an average of 5.5 years. And this is the type of deformity. They're all high grade. And you see the change in the slip percent listhesis and the slip angle. There were no neurologic deficits in these first 25 cases. And this is what the procedure consists of. There are a number of steps, and you need to do it exactly as outlined. Let's do the exposure, do a gill procedure, and expose particularly the L5 root, which is going to be in this area. And then place your screws. And I use reduction screws in L5 and sometimes in L4. I apply distraction. Then I do the discectomy and the sacral dome excision. And I put more salivary grafting the anterior part of the inner space. Then I do the gradual reduction with the screws, continuing distraction, place a cage and compress it, and do the posterior lateral graft. And this is about a 4-hour procedure. And we follow the L5 route by direct stimulation of the L5 route. And it's just about always increase when you first expose the needle to the L5 pedicle. And this should decrease a little bit and stay that way over the case. And we've never lost the L5 root response. And if the L5 root responds to stimulus, I think you can be pretty confident that there's not going to be an L5 lesion after surgery. And this is an example, high-grade, high slip angle. And this was done L4 to the sacrum, and using the L4 screw to protect the L5 screw during surgery. And then after the reduction was complete and the tension band established in the cage in position, the L4 screw was removed. This is our publication in Keith Bidwell's 2011 textbook. The 2020 edition will be out this year. Personally, I've had over 100 high-grade spondylos, and the data is very much as reported for the 25 patients. There's been very few complications, no reoperations, and no L5 root injuries. And this is another high-grade spondy done by exactly that technique. Lesson 8 is the utilization of the Ponte osteotomy. I met Dr. Ponte in 1985, and he was a friend ever since. And this was his initial article using his osteotomy for Scheuermann's kyphosis. And this is our 27th publication on the first use of the Ponte osteotomy in the United States for Scheuermann's kyphosis. And prior to the Ponte osteotomy and pedicle screws, the standard of care for Scheuermann's kyphosis was anterior thoracic release and posterior instrumented fusion. And this is the Ponte osteotomy. It's done, the ligamentum, the posterior longitudinal ligament and ligament flavum are removed, and then the superior and inferior articular processes are removed. These can be removed widely, as shown here, which is necessary in Scheuermann's kyphosis, or less widely for lordotic deformities. It's easy to do, it's quick, and you should not have any injuries. When the osteotomy is closed, there's very little opening anterior, and that's how the correction is obtained. And here you see exposure, ligamentum and articular processes removed, screws placed, simultaneous rod placement, and cantilever across the apex. And this is a radiographic example of relatively high Scheuermann's disease, probably about 90 or 100 degrees. And this is a correction. Lesson number 9 was what I learned from Jürgen Harms and Lutz Biedermann in the development of the Moss Miami device. And this is, I believe in Korea, Professor Harms and myself. And this was the development of Moss Miami. And this was a multiple hook rod screw system based on a 5mm cobalt chrome rod. And by generous releases, patients, we had the ability to get excellent correction with a 5mm rod. This is our initial experience presented at SRS. And this is the use of Ponte in the thoracic deformities. And the Moss Miami descendants from between 1994 and the present are shown. It became product that DePuy initially produced, and then became DePuy Synthes. And Moss Miami became Expedium, and it's in about its 7th iteration. Lesson number 10, look at the patient. And I learned a lot just looking at the patient in terms of trunk shift, prominence, and what to do with the lumbar curve. And I like to look at the lumbar spine within prone. And this goes back to the selection of distal level in AIS. She doesn't have very big deformities. This is her x-ray. Not much of a lumbar prominence, and was even less in the prone position. And therefore, we chose to do a selective thoracic fusion, stopping at T11 with very good radiographic and clinical outcomes. Number 11, the vertebral column resection is very useful. I learned this from Professor Sook. He was a master surgeon, and the VCR is the Schwab classification 5 or 6. And this can be done posterior or combined anterior posterior. This is the 44 patients that I did a thoracic VCR for deformity back in 2004 to 10. And they were congenital or severe curves mostly. The VCR level was T4 to T12, and all pedicle screw instrumentation was used. And this shows the amount of correction, which is substantial, in the sagittal curve alignment. There were no neurologic injuries in these 44 patients. Two chest tubes were required. 25% had monitoring changes, which was reversed by the methods we discussed earlier. And this was a girl with very significant kyphosis and some coronal deformity. She had no other pathology, and we really didn't know what this was. This was her clinical appearance, significant deformity. And she had an asymmetric VCR thoracic 5 and multiple level Pontes with virtually complete correction of her scoliosis and kyphosis, and excellent clinical appearance. So the Fox study group was a group of 7 of us who looked at VCR in AIS patients. And these were by and large stiff curves. They were associated with a large blood loss, and one of our papers showed the advantage of antifibrinolytics, particularly TXA. It was about a 25% monitoring change, no permanent injuries, and a 36% complication rate. So it's complications to be expected, but everything can be manageable. And these are the references for the Fox study group present studies and for Sook's report. And finally, lesson 12. Your staff is very important, and it's important to have a team approach. So you want people to be happy and productive, and once you assemble a good staff, you want to retain it. And I think the key is to treating everyone as you would like to be treated. Don't humiliate people in public. If you have something to say to them, take them in private. But in that way, you'll manage to retain your staff and have low turnover, and everybody will be happy. 2 other things. Number 13, halo gravity traction is very valuable, and I've used it a lot over the last 10 years. It really does avoid the need for 3-column surgery. And this is an example. Very severe congenital deformities. Normal MRI. This is his 3D CT reconstruction. And he's got a lumbosacral hemivertebra and a thoracolumbar hemivertebra. And he went 6 weeks of traction with very significant improvement, particularly in the thoracolumbar kyphosis. He was then taken to the operating room where he underwent an excision of the hemivertebra L4 to the sacrum with this alignment, which is much better. And then he underwent a posterior-only multiple posterior column osteotomies to correct the remainder of the deformity. So other than the hemivertebral excision, he had no 3-column surgery. And the halo gravity traction will let you do remarkable things. And number 14 is the use of 3D printed models. I don't have slides on this, but in severe deformity, making a 3D printed model and having it in the surgical field is very valuable in defining the orientation of structures. So it's easy to get a 3D printed model. It's very helpful. So I think I'll stop at that point because that's the end and take any comments or questions.
So thank you very much, Dr. Shufflebarger. It's really great experience and a great journey, 30 years of these tips. So we have some questions, and so I will start with Dr. Firas. He asked about when you do DOM osteotomy in the spondy, reducing spondylolisthesis. And you put the cage, what the chances of cage subsidence in this case, and how you treat this?
Doing a sacral dome osteotomy, what's the possibility of cage subsidence?
Yes.
Well, when you're going to leave some of the end-plate, particularly laterally intact, and using a cage with a large footprint will minimize the subsidence. I use a banana-shaped cage, mostly called DevX. And having iliac fixation, S1 fixation, and good fixation at L5, I think will take some of the load off of the anterior column. And subsidence just has really not been a problem.
So now after like 30 years experience in scoliosis surgery, so what's your rule or daily rule to choose the lower instrumental vertebra?
What's my thoughts about lower instruments?
Vertebra in the fusion level.
I don't understand.
So what's your criteria to choose the lower instrumented by vertebra in the fusion, in the skull, you can see?
Okay, criteria, in adolescent idiopathic scoliosis, you can look at the Lecky 5 and 6 as one group, and the LIV is going to either be L3 or L4. You should avoid L4 if possible. The situations where you'd have to go to L4 are when the disc space between L3 and L4 is wider on the left side than on the right side, meaning L4 is the lower end of the Cobb ankle. When the disc space is parallel or open the other way, you can always go to L3. And you can look at Lecky 1 through 4 as a group with similar rules for determining the LIV. And I look at the where the center sacral line falls in the B and C type curves. It's pretty easy, and I'll do selective thoracic fusion virtually all the time, choosing as the LIV the stable vertebra from the center sacral line, which is usually thoracic 12 or thoracic 1. For the 1 and 2 A curves that have a right configuration, meaning the body of L4 is tilted to the right, then I will do the barely touched vertebra by the CSVL, and that's usually going to be L2.
Okay, thank you. We have one comment from Dr. Tony Tannouri. You can go ahead and ask Dr. Tony.
Oh, hey, Harry, how is everyone? Harry, thanks for the presentation. So one question, actually, you just touched on it a little bit. I know the type 5 and 6 derotation, I learned from you. Could you kind of discuss how you do the type 5 and 6 derotation? That's one part of the question. The other part of the question is, Suk talks about the compensatory lower curve, whether it's in the same direction or the opposite direction of the main thoracic curve, and that would definitely affect the lower instrumented vertebra. Could you comment if you what are your references on this?
Yeah, I respect that Professor Suk very much.
Yeah, I know. That's why I'm bringing him up to you.
But I don't agree with a lot of the things he wrote in those couple articles on determination of fusion levels. I don't agree with his classification scheme, and usually his method of determination is going to be one level lower than we would do. So I don't remember all the particulars of his article. It was very confusing. I had to read it probably 10 times to get what he was saying.
I mean, my concern with this is if you the lower curve, it rotates in the same direction as the main thoracic curve, and then once you do the correction of the main thoracic curve, actually it will exaggerate the lower rotation of the segments that you left untouched, and that's why probably he recommends going one level more. But if the lower compensatory curve is rotated the opposite way, you can go shorter because your correction of deformity will help correcting the deformity. So I was wondering what you think of that. But I know you have your own technique of doing the derotation on the type 5 and 6. If you don't mind sharing with the group.
Let's talk about the lumbar curve, where you're going to do the thoracic curve, and where he's talking about the rotation in the same direction is the 1 and 2A Lenke curves, which is where if you don't do it distally enough, it's going to add on.
Yes.
And I think that's not a problem in technique as much as it is in a problem of not really understanding the curve and the vertebral rotation direction. And you can get this from plain films, but it's better seen on the EOS 3D reconstructions. Because the end of the Cobb angle may be T12, but lumbar 1 is rotated into the curve and lumbar 2 is rotated into the curve. Mm-hmm. And you may have a tendency to stop at thoracic 12, and that's a high percentage of the time going to have adding on.
Thank you, Dr. Tony. Sorry. So there is a question from Dr. Firas. Can you go ahead? You are unmuted, Dr. Firas, and ask your question.
اسكت راح اسال سوري Thank you, sir. I just want to ask about the derotation and the osteotomies in the lumbar curve. Usually we do a derotation and then the Smith-Peterson osteotomy. I faced one surgeon who has experience of doing osteotomy and then derotation. Is that possible, or you have any experience about this?
The technique I use in lumbar curves is I will do the exposure, and then I will do the pontiosseotomies. And these need to be wider on the convex side than on the concave side. And many times, the apical 2 or 3 levels, the osteotomy will be from pedicle to pedicle. After the osteotomies, I'll place the screws, and I use all uniplanar screws on the convex side and polyaxial on the concave side. And then I will do the convex rod insertion. And I will start it in the apical screw and enter the screw, close the screw, derotate that vertebra using an instrument on the next proximal vertebra as a counter torque, derotate it and tighten it. Then I will go progressively from the apex distally with the sequence of entrance of the next screw with the rod, closure of the screw, and a combination of derotation and compression relative to the apex. And I'll proceed distally until I've got all the screws in, and then I'll do the same process proximally. So the derotation is done after the osteotomies.
So is there any risk about the neural element if we derotate the spine while it is osteotomized?
With just pontiosseotomies, no.
Thank you.
Okay.
Can I ask a question? If you don't mind?
Yes, please, Dr. Bako, go ahead.
Yeah. Thanks, Harry, for a nice lecture, really. Do you believe in non-fusion correction, the tethered cords? I use it, or you recommend it, or any experience with it?
Do I believe in spinal vertebral tethering?
Yeah.
Yes, I think there's a certain place for it. I don't think it's the answer to all spinal deformities. I think the place is going to be in the adolescent who is immature, ideally premenarchal, Sanders grade 2 or 3, and curve less than 60 degrees. I think that's the ideal candidate for it. I think many people are stretching the indications for it, and some people are doing it on everything, even mature people.
Exactly.
I think the results on these are to be determined. But I think in the setting I described, I think the results are relatively good. You know, the patient and the parents have to be prepared for the need for a second operation 10% of the time. Mm-hmm. And for me, the selective thoracic fusion ending at T12, the results of that are really hard to beat.
And do you do also the selective fusion anterior sometime?
Back in the 90s, I did some anterior thoracic fusions. I think you can do better posterior.
All right. Thank you.
So, is there any other questions for Dr. Shufflebarger?
Abdul Jabbar, can you request Dr. Harry to share the neuromonitoring checklist slide again for a moment, because a couple of guys have asked to
Yeah, actually, I will send to them. I have a record of the presentation. I will send it to them. for
Okay.
the slide,
Thank you.
just to save time.
Thank
so,
you,
Dr. Hari,
Great presentation.
last
Thank
questions from me. So, what's your rationale to do the costoplasty for each case? When I visited you 2 years ago, like you do it for each case.
Yeah, yes, we do it almost all the time. Going back in the Harrington Raw days, we did costoplasty all the time. And then Cottrell Dubussé came out, and Jean Dubussé said, you don't need to do costoplasty because the derotation is so good. And so I stopped doing it. Initially, it looked pretty good, but a year later, the rib prominence came back. So I started doing thoracoplasty again. And when pedicle screws came out, everybody said, well, you don't need to do costoplasty here. But I stopped doing it, and again, the rib prominence comes back. So the reason a lot of these patients are there for their deformity surgery is they hate their rib hump. And I think the way to reliably get rid of the rib hump almost all the time is to do a good scoliosis operation and to do the costoplasty.
Can I ask a question, Abdul Jabbar?
Yes, please, Dr. Saeed. Go ahead.
Thank you, Dr. Hari. Great presentation. You mentioned you use halo gravity traction for adolescent advanced scoliosis. Do you use halo pelvic traction for very advanced spondylolisthesis before you proceed with your surgical procedure?
No. I don't think it's necessary. I don't use halo traction for spondylolisthesis. I think if you do an adequate operation, it really isn't necessary, even for spondyloptosis.
Yeah, I saw your article in the JBJS, which clearly mentioned the same steps you mentioned here. The reduction. Okay, thank you very much, Dr. Shufflebarger. It was a great time to give us your experience, and thank you very much for everybody who attend this webinar. Next week, almost the same time, we have one speaker who will speak about the spine tumor, metastatic spine tumor. So it will be next Thursday at 5 p.m. Doha time. So you are welcome all to attend. And thank you again, Dr. Shufflebarger.
If you'll send me the invitation, I'll try to make it.
Okay, sure, I will send it to you.
Okay.
Thank you again.
Well, thank you everybody for listening. And
thank you very much. Thank you.
Thank you. You have a good day.
Thank you.